I was actually asked to do two things. One was to talk about what we can learn from developing countries, and I was also asked to just spend a moment or two on aid, and whether aid was a good thing or a bad thing. So I'm actually going to try and tie those two things in together. But I suspect my colleagues who are going to speak afterwards will manage their 2 minutes on whether aid is a good thing or a bad thing. And there isn't, of course, as you appreciate, an answer to that question, or at least I don't think there is. I got involved in global health when the then Prime Minister, Tony Blair, asked me if I'd look at what more we could do to support improving health in low and middle income countries. So he got me to go and travel and meet a few people in 2006. And I came back and I produced a report called Global Health Partnerships, which actually really said three things. First one was, for goodness sake, stop telling people what to do and start helping them to do the things they know that they want to do. So turn it the other way around. Amazing that you have to keep saying that. The second one was that we have this extraordinary, wonderful education system for health professionals and people working in health generally, which you're all part of at this moment. And the biggest need in many parts of the world is for more staff. The biggest need is to get more people trained. I know migration is an issue and we might touch on that, but actually when you go to a country like Ethiopia, and until very recently they were only training 100 doctors a year, and they're bigger than us, and we train 8,000 a year, you actually realise that there's a big issue about how you get more training and development. But the third thing, and the thing I wasn't expecting to discover, was how much we can learn. You know, there may be a lot that we can teach and support, but there's an awful amount that we can learn. And I'm going to run through a few slides on that really very quickly, and I'm assuming this is the thing that I press. It is. So, turning the world upside down, the 5 things I'll touch on briefly: the global and local context, the way health and healthcare themselves are changing, some lessons from an emerging tradition, partnerships and co-development, and some opportunities we should all get involved in. So let's touch on the global context, the very big picture. What we all understand, I think, very well is how interdependent we are in health terms. This is interdependent in the fact that a disease can spring up in some very poor country with poor health surveillance and then spread around the world very, very rapidly. We are as vulnerable in the UK as the poorest country in the world, which is maybe where the disease may spread from. Climate change, we know, doesn't respect boundaries. Climate change will have big health impacts, and the migration that may come from that, and so on. We also know we're dependent on the same groups of health workers, on the same drugs. We also see very clearly that as globalization continues, economic globalization continues, you see things like fast foods appearing in South Africa, and I was there very recently, and big complaints that we had food deserts in parts of South Africa, just as you do in the UK, where all you can get is fast food and stuff that's not particularly good for you. So that's a negative product of globalization. So we're interdependent. Within that, I argue that we have what I call an unfair health trade. We import health workers from poorer countries and in return export our ideas and our ideologies, whether they work or not. And actually you see the Americans exporting their ideas, which are rather different from ours, all over Africa. And I ask in his book, Turning the World Upside Down, what would it be like if it was the other way around? If we actually started to import some of the ideas of people without our resources and our baggage, and the things they have been learning and doing better than us, and in return export some of our workers to support what's needed in these other countries. As we know, there are massive shifts in power at the moment, which are really starting to have an impact, and will continue to have an impact in health, in terms of who sets the agenda. Big economic differences. You're all working in the NHS, or all sitting in the NHS at the moment, and the issue here is about contraction, about actually how can you reduce cost, how can you get improved quality for reduced cost. Actually, in a large part of the world, they're actually looking at expansion. India and China have both had big announcements in the last 2 or 3 years about having major improvements and expenses from a low base in their health. So there are differences around the world. But all of that means that I don't talk about international development, and I realise my little blurb you just read out did. I talk now about co-development, because actually we're all in this together. We know there are differences. You've seen these sort of maps. This is where the HIV/AIDS epidemic is, which may get talked about a bit later on. But this is, numbers of deaths and where the biggest deaths are. No surprises. This one, of course, is non-communicable diseases, and you can see that's a worldwide global epidemic, with that bloated pink thing at the top there being the UK. which is maybe what you would expect and where our diseases are coming from. But Africa has got the fastest rate of increase of diabetes, for example, so this is a global epidemic. And let me just be clear that when I'm talking about low and middle income countries and learning from low and middle income countries, I do understand that people there mostly are working in very great difficulties, that poverty reinforces health problems, social issues and relationships do. There are these extraordinary shortages of resources and health workers. I was in Oxford, the JR recently. I think they have 600 doctors. If the JR was in Africa, in most African countries, and they were dealing with the same burden of disease, they'd have about 12 doctors. That's the sort of proportional relationship that we're talking about in terms of the differences in some of these countries. And people are dealing with non-communicable as well as communicable diseases and maternal mortality and so on. Here's a very simple map which actually shows the relationship between the distribution of health workers and the level of and the burden of disease. And so you can see in the top left-hand corner, Africa has got 25% of the burden of disease in the world. It's about 10% of the world's population. It's got 3% of the health workers. Come over here, and the Americas have got maybe 10% of the world's burden of disease and 35 to 40% of the health workers. Very stark picture. We also know that actually solving this isn't just about clinical medicine. Indeed, the bigger impacts are going to come from things in the public health field. And I've just illustrated this very simply on the left, that actually there's a downward spiral of ill health, poor education, high birth rates, bad housing, unemployment, crime, conflict. All of this adds up to a very unhealthy climate. On the right-hand side, there's the upward spiral, starting with girls' education, probably the single most effective health intervention there is. I'm glad that Rifat is nodding as I say that. That and clean water, that may lead to low birth rates, better nutrition, safer societies, and higher household income. So, you know, we're thinking about health in that sort of much wider context. So, let me just touch on the other thing that is the relationship between the rich countries and the poor countries. I've already touched on health workers, and you asked me just to say a word or two on aid. Well, I think there are some very specific things that have come out of aid. When the sort of world's history of international development and aid is written in 100 years' time, I think you'll see some extraordinary achievements around some of the specific targets. I think there's been real impact. We'll probably hear from the Global Fund later on, actually, but Gavi, for example, that does immunisations. I mean, there have been extraordinary impact on actually achieving things and making a difference and keeping children alive. There's also been, I think, great awareness, and civil society has become much more active around aid in ways that I think are extremely positive for the world as a whole. But there are also some negatives. One of them is this point that I suspect people will know about vertical systems versus systems. This is where you get an organisation that is perhaps dealing with one particular topic, be it HIV, AIDS or TB or something like that, and it is setting all the target and all the money into that vertical programme, and as a result maybe drawing in people and resources from other areas. So you may get improvements in HIV, AIDS, but actually worsening in maternal health or some other areas because of that. So there's a great tension there about us coming out from the outside and wanting to make a big impact and saying we've got to crack this problem of AIDS or whatever, but recognise, like everything in life, there are consequences, there are some downsides. And the other aspect of aid is it does and can build dependency. And I suspect my colleagues and I have all been in rooms in Africa where we've actually heard Africans saying thank you very much for the aid, and then actually later on, if you happen to be in the bar with them or afterwards, actually describing what some of the consequences are, and you know that they're spending their too much time trying to deal with the donors and look after us who have come up with the money, as opposed to getting on with things themselves. So I think there is a real issue about dependency. So there's a balanced scorecard here, and we can talk a bit more, but those are just 4 quick concepts. But it's also why I talk about, instead of international development, I should talk about co-development. It's important to us that other people's countries have safe and effective health systems because of what impact they have on us. Let me move quickly on to what's happening in health globally. Major changes happening. Since our health systems in the UK were set up effectively in the, sort of roughly speaking from the sort of 1920s to the 1980s, life has changed. The diseases we die from have changed. It's much more about non-communicable diseases, as we know, which need different sorts of treatments, much less hospital-focused, much less physician-focused. Patients and the public have changed, much less deferential. They're also part of the issue, part of the problem, part of the solution when we talk about many of the diseases you will be dealing with as doctors. You get into talking about behavioural change and all those sort of aspects as opposed to things that your grandparents' generation would have been doing. Science and technology changing very fast, health is becoming global. And all of that means that the healthcare systems we have are going to have to change really quite radically. In your lifetime as clinicians, we will move to a much more community-based, much more people-based, much more multi- and indeed trans-professionally based way of delivering healthcare. Very difficult change, which we will be needing to go through. Where are the bright ideas going to come from? Well, I would argue some of them are going to come from low and middle income countries. We actually see some of that in specific examples in HIV/AIDS. It's not surprising, there's quite a lot of the innovation there has actually come from low and middle income countries because that's where the disease is. You can also see this with a number of specific conditions, which I won't go into for interest of time. You can see it in policy initiatives. There's something called conditional cash transfers, which was a major policy to how do you reach healthcare to the poorest people in a society. This was something that was developed in Mexico and has since been transferred around the world and was explicitly in New York, actually introduced by the mayor of New York. And he, when he introduced it, it used to be called Oportunidad Mexico and is now called Opportunity New York. When he introduced it to New York, he explicitly said, we borrowed this from the Mexican countries. We see product development in a whole range of areas where people are trying to grapple with really difficult issues. We see, for example, that to deal with cataracts in India, a very exciting organisation called Aravind has developed new lenses. The lenses previously used to cost $60 to $70, they now cost $5 to $6. And this was in a response to the needs of that country. People started to develop things differently. Telemedicine, we will see more interesting innovations happening around in countries which don't have wires. And all of this is starting to be identified by these commercial organisations. Indeed, this slide here, which I pinched from McKinsey's, with their permission I hasten to add, shows where they think the most interesting innovations in healthcare are happening around the world. And this is a commercial management consultancy organisation. And you don't need to look at the detail, though you can have copies of these slides if you want. But look at the map, look at where the green is. Fair amount in India, which is what you'd expect. Quite a lot in Africa, actually, which you might not have expected. And then not a lot in Europe, and nothing in China. Now, this way, somebody else could provide another map of the 25 most interesting innovations, but it probably wouldn't be that different from this. Right? People are innovating because they don't have our resources, they don't have our baggage, they're making change. And the most interesting innovations, and the ones I think we can really learn from, as I rush towards the end of my 15 minutes, is actually not about specific innovations, but about ways of doing things. Many of the countries that I'm talking about have much better ways of involving the community, family, and particularly women in healthcare. And when you're looking at the needs we have in this country for changing behaviours and so on to deal with non-communicable diseases and so on, we need to get better at involving communities, family and women. Many countries don't make an artificial separation between health and education and work. And I know that I think Alistair has put in as a reading, or maybe it was Vivek, put in as reading for you today 3 pieces, one of which included an organisation called BRAC in Bangladesh. Very interesting organisation. They will work with a woman on the health of her child. They'll also provide her with education, and they may also be able to provide her with a microfinance loan so that she can start some small business. So you're actually dealing with her as a whole. You're actually helping her to live her life, rather than treating the healthcare bit as something completely separate from everywhere else. Social and business enterprises, many very interesting developments happening around the world where people are creating social enterprises as opposed to government organisations to make change. Linkage, which I think Elder is going to talk a little bit about between public health and clinical medicine, bringing those traditions together, which got separated in this country and even more separated in America 100 years ago. But the real importance, for example, of the community workers in Ethiopia that actually work at the most local level, most of what they do is public health type issues, but they also do some treatments and bringing that together. And then the radical one, which is actually about training people for the job and not just the profession. The one that's the really contentious one when you think that in Mozambique, most of the cesareans in Mozambique done outside the capital, 95%, are done by nurses with a bit of additional training, as opposed to by doctors. Most anaesthetics in Africa, I think, are given by people who are not doctors and so on. And you can actually begin to see now where that works and where it doesn't, because many of those examples haven't worked. The cesareans in Mozambique has worked because there's been training, appropriate training, retraining, supervision, ability to refer on. These are the sort of criteria for success. So there's some real lessons there when you start to think about what our problems are going to be, what your problems are going to be working in the NHS, is how do you get the community to help look after this elderly lady who's come into your hospital 3 times in the last month? How do you start dealing with some of the other impacts in her life and not just the ones you can see through you know, on your piece of kit or whatever? And how do you get the other people in her life, whether they're volunteers or people in social care or whatever, to work alongside you? You're working trans-professionally, not just with the professionals, not just with the nurses. You're working across the whole system. So terrific opportunities. I think the great opportunities are in education and training and changing the way that happens, in developing partnerships and co-development, in people like you spending more time with your equivalents and your colleagues in Ghana, as I know some of you have just been doing, or wherever. And remembering the very simple point that as we go forward in the future, everyone has got something to teach and everyone has something to learn. Thank you very much.